First of all, I'd like to thank TVS for inviting me here today to share some thoughts on clinical management of biofilms. But first of all, I would like to inquire how many non-nurses are in the audience? Do we have any physicians amongst that group? Podiatrists? Academic researchers? Commercial members? Okay, thank you. That helps give me some form of balance as to how I should proceed. So, how do biofilms affect my clinical practice? I've not included my as the personal pronoun. I'm referring the my onto you guys, because I want to explore with you how biofilms have affected your clinical practice. So let's see what unfolds. It's all about choices. Now, there are 3 doors there. First of all, I'm just going to discuss or present to you 2 doors, and we'll come on to the 3rd a little bit later. So the first question I'd like to ask you is, you are all well experienced in managing acute wounds. How has that management of acute wounds been translated into managing biofilms, otherwise known as chronic wound infection? Have you changed your practice from acute mode into chronic mode? Sudden silence. So what's happened? Have you changed your practice? Yes or no? You have? I'm not going to ask you for specific details, so you're off the hook. Anybody else? Have you changed your practice? Or are you still sticking with acute wound management? Mostly sticking with acute wound management. Okay, so now I know where we have to explore. Because if you're making the wrong choice, if you're still sticking with acute mode, you're not going to get anywhere, or you're not going to get very far. So I'd like to pick up on what Val explored, the planktonic and sessile relationship. Because it's all about behavior. Now, the term planktonic comes from the ancient Greek, planktos, and it means literally drifter. And as Val clearly explained, these entities float around in fluid, and they are looking for a place which they can attach and then develop into biofilm phenotype. So they are plankton-like. They float around. But this phenotype is fiercely competitive. They're competitive with other bacteria. They want to dominate in many instances, and they are extremely predatory. And that's what gives rise to the host reaction that we all rely on: redness, swelling, heat, and pain. It's how the body responds to this predatory invasion by planktonic phenotype. On the other hand, biofilm bugs are attached to a surface, and they behave quite differently. Their remit is not to dominate, not to kill. Their whole purpose is to survive. So they behave completely differently. And we can learn from this quote from Kostadin in 1999, biofilms constitute a protected mode of growth that allows survival in a hostile environment. They want to survive. So they act differently to planktonic. Their mode of action is more parasitic. They want to live off the host. They don't want to kill them. They don't want to kill the host. They want to survive, and they often live off the exudate, the fluid that's expressed in the exudate, and the minerals and nutritious agents that are within that exudate. So they do not have a vested interest in killing off the host. So when did this science of biofilms start? How long ago do you think we were made aware of biofilms? 1800s, 1900s, 1950s, 60s, 70s, 80s? Where in history did it all kick off? When was it turned into a science? What's that? 20 years ago? Not bad. That is the first paper that I can find on biofilms. I don't know if Val has anything before that. You'd agree? Okay, 78. So Bill Kostadin, who's generally regarded as the father of biofilms, he was a Canadian. He died 2 years ago in May 2012. And he was a great lover of the outdoors. He loved climbing mountains and hiking. He loved the wilderness. And sometime after this paper, published in 78, he wrote about his experience that led to the production of this paper, how biofilms stick, how bacteria stick. And what he declared was that he was hiking in the mountains in a place called Bugaboo Spire Glacier in British Columbia. And he had an embarrassing fall. He fell backwards on some granite rocks that were by the side of the glacial lake. And as he came in contact with the surface, he noticed this slimy material that drew his attention. Now, at that point in history, if you took a sample from glacial waters, you would expect to grow about 8 bugs in 1 ml of fluid. So very, very low bacterial count because of the cold environment and that this water has come from glaciers. But when he took this sample off this rock and back to the lab, what he found was it was teeming with bacteria. Many, many bacteria, that more than you would expect to find in a sample at that cold altitude. And that set him off on this path of investigation, and later on he published widely on chronic infections, especially involving indwelling medical devices. And he stated on many occasions that bacteria grow in well-developed glycocalyx enclosed biofilms. We tend to use the term EPS now, extracellular polymeric substance, in place of glycocalyx, but that was the term used at the time. And so his investigations and others led on to investigations in science looking at the biochemistry and genetics of biofilm formation and function, and a search for new methods for medical diagnosis. But where we need to take note is that the development of science within this arena is needed, but we need to put it in a clinical context and firmly grasp the fact that biofilms create a therapeutic problem. We cannot continue looking at chronic infections with our acute eyes on. We need to switch our vision and consider that these are chronic infections and really need an entirely different mode of management. And as Val indicated before, biofilms are resistant to conventional antimicrobials and also your immune host defenses. So we need to understand biofilms, we need to get to grips with them, and also learn ways in which we can control them. So this takes us back 150, 60 years. Who's heard of Robert Koch? Anybody? One? Only one? Nobody's heard of Robert Koch. Well, we've a lot to be grateful for from Robert Koch and his studies. He engaged heavily in examining the anthrax bacillus. And from his co-workers, Walter Hess, we had the development of the agar medium, which is used in every lab. Tons of agar are plated into Petri dishes every day, and it's the traditional growth medium for microbiology laboratories. And mentioning the Petri dish, that was one of Robert Koch's associates, Richard Petri, developed the Petri dish. So we've a lot to be thankful for this fine Victorian hair-suited gentleman. What he said was a number of criteria need to be met for a microorganism to be identified as a disease-causing agent. And that led to what we call Koch's postulates. They are all important, but I'd like to pick on this first one. Microorganism must be evident in all episodes of the disease. Does that apply to biofilm infection? No, because we can't grow biofilms in the laboratory. So if you can't grow them, how can you identify them? And how can you satisfy the first of Koch's postulates? The microorganism must be evident. Well, if you can't find it, it can't be there. But it is there. We don't have the technology in order to culture them in the traditional mode. And if we look at the fourth one, the microorganism must be isolated from the host that is diseased. The same applies. We cannot isolate biofilm phenotypical bacteria. So if we can't identify them, how do we know that we treat them or when to treat them? And how do we know when we've been successful if we have treated them? So it's all very difficult, isn't it? And that is what makes it very difficult for us to switch from acute mode into chronic mode in their treatment. But let's have a little look at that. Now, this paper was published tail end of last year, and these researchers looked at sternal wounds, and they declared that they had identified biofilms in these sternal wounds. And these are two scanning electron micrographs. The one on the left, as you can see, is at times 60 magnification, and these are sternal wires. And this substance on the sternal wire has been magnified and is identified in more detail over here. So what the researchers claim is that this is evidence of biofilm growth on these sternal wires, and that obviously that has to be managed, otherwise the wound will not heal. Over here at times 10,000 magnification, you can see morphology consistent with cocci, and the researchers suggested that this is cocci embedded in what we would call the EPS, the slime material. But as there is no definitive assay, we can only go on the presumption that this is biofilm, evidence of biofilm formation. So, how do we manage wound biofilm infection? It's obviously going to lead to a lot of scratching of heads. How many of you have heard of biofilm-based wound care? Okay, half a dozen. What do you know about the concept? What are the elements of biofilm-based wound care? Any suggestions? What are the components? Debridement, great. Next one. I'm sorry? Okay, all right. To break it up, yeah. Any other components that you're aware of in biofilm-based wound care? Sorry? Antimicrobials, okay. All right, that's pretty good. So those are the three components as identified by a team of researchers in Texas, led by Dr. Randall Walcott. And this was published in Journal of Wound Care in 2008. So debridement, topical agents, antibiotics. But the important thing is that these are multiple, dynamic and concurrent, not consecutive, strategies. So you do all three at the same time, with the intention being to weaken the biofilm until it reaches a level at which the host can regain control. The treatment must suppress the biofilm, but not damage the host defenses or the host healing mechanisms. So we'll go through those three components, and you can give me some feedback as to how you view them. So if debridement is the first and perhaps major component of managing biofilm-infected wounds, and Randy Walcott and his colleagues recommend repeated sharp debridement, how many of the nurses here regularly engage in sharp debridement? Half a dozen or so. Great. And do you use a knife, scissors, scalpel? Okay, great. Well, the intention is to debulk the bacterial load on the surface. You then open up these packets, and on doing that, you stress the biofilm. And as you stress them, you immediately make them more vulnerable to your topical agents, your antibiotics, and your topical antiseptics. So within the world of wound care, there is a need to physically disrupt the biofilm infection. Now, Val mentioned patients with cystic fibrosis. You can't go in there and physically disrupt all the biofilms lining the lung. You just can't do it. But in wound care, we have to. Otherwise, you're not going to get anywhere. So sharp debridement is extremely important as a management tool. But we need to remember, and again, as Val mentioned, there is a short therapeutic window in which we can gain an advantage over the biofilm because they quickly reform within 24 hours. So within that window, we need to keep up the stress on the biofilm through the topical agents and the antibiotics to keep them vulnerable so as we are on a better path to regain control of this infection. Now, Randy goes in deep and he goes in hard. And I've seen him debriding some wounds and you think, crying out loud, the poor patient, and I could never engage in such radical debridement. But he is a physician and he has the skills. Most of us as nurses can sharp, or many of us as nurses can sharp debride, but we can't really go back to bleeding tissue. And I've seen him open up wounds like this and drain a load of effluent out, which is foul smelling and foul looking, and repeated debridements will take it back eventually to clean tissue when it is allowed to heal over a period of time. And he has great success in limb salvage, especially in the diabetic foot ulcers. And of course, you are then saving huge amounts of money in rehabilitation because the patient still has a functioning foot and they can still then go back and to gainful employment. It's important to remember that We also need to use appropriate dressings, and although dressings can provide a degree of autolytic debridement, it does not have, in all instances, the same therapeutic value as sharp debridement. So autolytic dressings are used as an adjunct. One tool that he does use, I don't know if this is available in the UK, and of course, those that can't sharp debride really need to liaise with their colleagues in podiatry and in perhaps vascular surgery or general surgery to help with regular sharp debridement. But Randy Walcott regularly uses this device, which is a pulsed plasma radio frequency debriding tool. And it gives very precise debridement with control of bleeding, with very little, if any, collateral tissue damage. And he relies heavily on this and has achieved great success in many patients with this peak plasma blade. There is some research to support this, and I look forward to seeing if it works as well in the UK. Now, I was surfing the internet on Monday and I came across a posting from NICE when they, in their medical technology guidance number 17, they have produced a report on Debrisoft. Now, you would have seen at the beginning declaration of interest, none. I have not been paid for this session. I don't like to mention brand names, but as there is only one monofilament debriding pad, I can't escape mentioning Debrisoft. But it appears to work very well. It appears to be an alternative to sharp debridement, but what we would ideally need is a comparative study comparing soft debridement with Debrisoft and sharp debridement with a blade. So the statement from NICE said that although there is uncertainty in the cost model, the use of the Debrisoft pad could generate cost savings compared with hydrogel gauze and larvae therapy. So it's worthy of note, and I think we should pay attention to that report. So let's go on to the topical agents. So biocides, anti-biofilm agents, and antibiotics. And this is now the model that they used up until recently in Texas, where they would use silver, cadexima iodine, honey, often a buckwheat honey, and PHMB. And they would use these in rotation. So 2 weeks silver, 2 weeks iodine, 2 weeks PHMB, 2 weeks honey, and then back to the beginning again, in order to keep up the stress on the biofilm, not allow it to get used to anything. And then they would use anti-biofilm agents, often consisting of lactoferrin. Lactoferrin we have in our bodies. It's abundant in breast milk. It binds iron, so it prevents bacteria using iron. They need iron just as we do. So lactoferrin binds iron. Xylitol, many of you will have seen that on toothpaste tubes. It is an anti-biofilm agent. I think you'll agree with that, Val, anti-biofilm agent. And Randy Walcott used to, up until a year or so ago, mix it up in his laboratory and apply a topical potion of lactoferrin and xylitol. He would often mix it with farnesol, which is a quorum sensing inhibitor. Farnesol is derived from plant oils. You find it in rose oil, jasmine, ylang ylang. It is a known quorum sensing inhibitor. It prevents filamentation in Candida albicans and prevents biofilm growth. He would use other agents, hamamelatanin, and aspirin, which some say is a quorum sensing inhibitor. I don't know if you have any experience of that. The first time I came across it, and they would mix this up, and it would look like a hydrogel, an amorphous gel, and that would be placed on the wound, together with topical antibiotics. Now, these tools aren't available to us in the UK or indeed in Europe. As far as I'm aware, there are only 3 topical antibiotics that are licensed for topical use: metronidazole, fusidic acid, and mupiricin. But in the US, they have a whole range of antibiotics that can be applied topically. So we are disadvantaged. If I mention to a microbiologist in the UK topical antibiotics, they start tearing their hair out. It'll lead to increased resistance, and all sorts of plagues will be sent to us. So the other thing about the antibiotics is that they are personalized in that they are prescribed according to the microbiological profile of that sample, and that's identified through molecular analysis, not through culture. So molecular analysis entails identifying the bugs through their genes, not through their growth profile. And they are also prescribed long and strong, so long periods, about 3 months, and in heavy doses. But things have changed. Recently, he has now switched to heavy reliance on a product called iodofoam. So this is a PVA foam, not a polyurethane foam. It's a PVA foam heavily impregnated with iodine. And he now uses lipogel, which is again an amorphous hydrogel, but it has lipids in it, which are extracted from breast milk. And there are a number of quorum sensing inhibitors. Furanone is one of them. I don't know the identification of the others. The manufacturer keeps those details close to his chest. And again, they combine this with topical antibiotics. So there's the iodofoam. As it gives up the iodine, so it blanches, so you know when the dressing needs changing, which is after about 3 days or so. And there's the lipogel. And from this study by Scott Dowd, published in 2009, there's a short sort of summary of their use of these two, the dressing and the lipogel. And what they found was these systems are not solubilized or dispersed in the presence of wound exudate, thereby significantly extending residence time in the wound beds. So they proclaim they go on lasting for longer periods of time. Now let's have a look at the antibiotics. Here's an important quote here, 2010. In patients that lacks signs of local wound infection, so we're now talking chronic infection, potential biofilm infection, systemic antibiotic therapy has been shown to be minimally helpful with efficacy as low as 25 to 30%. So if we stick with the acute mode, we're not going to get very far. So here is a list of a number of the antibiotic protocols that they use. You can see the groupings here and when they use them. I'm not going to dwell on that because we can't use this. And there are the systemic antibiotics that they use, but they now heavily rely on these three: amikacin, colistin, and linezolid. 2 minutes and I'll finish. So Randy Walcott's main thrust is based on personalized medicine. So we don't have a blanket approach to biofilm care, we personalize it for each individual patient. And in October 2013, in the USA, the FDA have published paving the way for personalised medicine. And where the FDA go, often Europe then follows in later years. And what that document does, it provides an infrastructure to help make personalised medicine possible. I'll just skip this one. Here is some evidence out of Texas where they've used personalised medicine. There were three, it was a retrospective study, 3 groups, the first one being standard of care, and then 2 treatment groups. Treatment group 2 is the lattermost group where they have used personalised medicine. The results being treatment group 2 healing increased to 90%, time to closure decreased by 46% compared with the standard of care group. So pretty good results. There is a summary between the standard of care and treatment 2, and you can see that demonstrated in that graph. And I'd just like to finish off with surviving infection. If we're to engage in managing infection, at the moment we tend to concentrate on eliminating pathogens. We want to kill them with the antibiotics and the topical agents. But this is an imperfect strategy because we don't kill them all, and we always leave some bugs behind which generate resistance and lead to selection for faster growth. So an alternative has been suggested whereby we look at damage limitation. So we don't necessarily focus on killing the bugs, but more in reducing morbidity. And we can do this through promoting host antivirulence. We can do that by promoting or constraining toxin production from the bugs. We can promote host disease tolerance, and we do that through modulating MMPs. How do we do that with ease? Well, how can we modulate MMPs in wounds? Any idea? Now, I bet Alison used to do this regularly some years ago without knowing it. Did you use, maybe you still do, use zinc oxide paste bandages on? Well, zinc is a protease modulator. And that's why the patients go, when you put it on, because it's damping down all these excoriating proteases. So we have the tools at our disposal, or at least some of them. We need to make best use of them. Antihistamines. How many apply antihistamines? Morganella morganii expresses histamine as a virulence factor, does it not? And you can manage histamine production with cetirizine, 10 milligrams twice daily, and ranitidine, 150 milligrams twice daily. So we do have some of these tools. Pro-tolerance drugs. We can use non-steroidals, ibuprofen, for instance, and steroids. And antivirulence agents, and Val has already mentioned quorum sensing inhibitors. In the interest of time, I'll leave it there. Thanks for your attention.